doctors from Sri Ramakrishna Hospital and also from the city of Coimbatore who have joined this webinar online and offline. I welcome all of you on behalf of Sri Ramakrishna Hospital management for participating in this today's webinar, which is one of the series of webinars we have been conducting for the last 2.5 years. And we all thank you very much for the extended cooperation you are giving for the last more than 2 years. Today's speakers are our senior radiation oncologist, Dr. Karthika, who is going to talk about radiation therapy, when and why. Why radiation therapy should be given and why it should be given. And the other speaker being Dr.N. MohanaRaj, senior surgical oncologist of our hospital. And he is going to talk about the role of family physicians in oncology. So I am also, both are interesting topics, and I'm also interested to listen to it and waiting for the lectures to happen. And secondly, I would thank both the speakers of today for accepting our invitation and coming and taking their time to participate in this webinar. Thank you, both of them. And first, I would like to call upon Dr. T. Karthika to take over the chair. Thank you.
Thank you, sir. Thanks for your kind words. Yes, sir. So good evening to one and all. So it's a topic which has been maybe a repetition, but what I feel still is most of the, whether it is a physician or the general public, the awareness on radiotherapy is definitely lesser when compared to other fields in medicine. So so that's why I thought, okay, we will embark on the same topic, but with a new addition and new dimension to that. So what we know about and what we don't know about radiotherapy, and when and how and why and what about radiotherapy. So let me tell you when all this started. So it's we call it history, but I feel it is very important that we know about our great people so that we respect them and we understand after how much pain and sacrifices we are into a department like this. So that was Roentgen in 1945 to 1923. He was a German physicist, always working on some kind of rays, and he didn't know what kind of rays he was handling. That is why he named it as X-rays. X means unknown. And for his invention, he received the Nobel Prize for Physics in 1901. Why I've mentioned the cause of death for these great people, or it's because they've been handling radiation for a long time. Exposure to radiation can induce a lot of hazards. That is why we really scare about radiation in every place. And he also died of bowel cancer. And then I would like this lady is a great inspiration for me, and she has done marvelous work in the field of radioactivity. Though radioactivity as such was found by Henry Becquerel, maybe at around the same time. Marie and Pierre Curie, couple, and they worked finding out polonium and radium out of the ores. Like they used to carry a piece of the ores in their pocket, not even knowing how hazardous it was. Though they were studying, though they know it is all radioactive, and they were studying about the physics aspect, but they did not understand the biological aspect of these hazardous substances, and they were carrying it in their pocket. And the reason why she died in a very early age by aplastic anemia, and that was also due to radiation exposure. She was the only person who received Nobel Prize in two dynamic fields. One was physics in 1903 and one was chemistry in 1911. So again, what happened, how the development happened in field of radiotherapy? It was first Dr. Charles who used X-rays in the treatment of malignant tumors. So now they know, yes, radiation is destructive. It is destroying biological tissue. Then why not we use for the noble cause? So they tried using X-rays for malignant tumors in the lab first, and then it was coated and hardened together. They used to treat X-rays for laryngeal tumors. Now, initially, radiotherapy was delivered as a single or one or two doses, whole dose, say about 15 gray or about 20 gray, single doses. So these single doses were, of course, reducing the tumor, but there was neither cure, and the morbidity was so high that the patients were not able to tolerate the radiotherapy. Skin was peeling and lot of oozing, lot of great morbidities. And once it's healing also, it was a heavily scarring. So now they thought, what can be done? What is this? It is reducing the tumor. It is killing the tumor cells, but we are having so many problems with using the radiation. Then how can we do this? Then Coulthard thought about dividing the dose into very small, small fractions so that we are able to spare the normal tissues. He was the first person who designed the fractionated radiotherapy, which we are all using today. So, like we give only 2 gray per day, and then we give it continuously for say 6 weeks or 7 weeks, daily one dose. The advantage was it was hitting the tumor cells. Say, for example, now we say radiation, the tumor cells in the mitotic phase are very sensitive. Now, when you say take a tumor, it has multiple cells and highly proliferating. That is why we fear this disease. Now, these cells are, half the cells will be in mitotic phase, half will not. Some will be in the S phase. In that situation, the cells which are in the mitotic phase or which are in the dividing phase will get killed first. Then what happens to the remaining cells? The cells keep moving in the cell cycle. So after the next fraction, again, when the cell comes to the mitotic, then when we give the second dose, those cells get died. Then the remaining cells keep multiplying. Again, the cell cycle goes on. And then again, the cells come to the mitotic phase. Then we give the third dose. So this goes on till we achieve what we call cure, or we call zero residual disease. So this is the aim of delivering a fractionated radiotherapy. So then we thought, okay, this is like using X-rays, which is from outside the body. Say we have an external machine which gives X-rays, and we are delivering the X-rays to the tumors. Now, Patterson was a pioneer in the sense because he was the person who thought, why can't we put the radioactive sources into the tumors so that the tumors can die off more better. So he was the person who gave us what is called brachytherapy, and we have what we still use the Patterson-Parker rules, which designs how we have to deliver the brachytherapy. Brachy means the source is very close to or inside the tumor. So that's what we term medically as brachytherapy. So there are a lot of sources. Initially, what we explored first by Patterson was radium. Radium was available as needles, and they used to implant the radium needle itself into the tumor. But imagine they were using or handling radioactive sources with hands, bare hands. They never understood that it is hazardous to them also. So most of the pioneers in radiotherapy who started all this, they faced a lot of morbidities induced by their own inventions. So that was the birth of the new field, which was radiation oncology. It's a discipline of human medicine concerned with generation, conservation, and dissemination of knowledge concerning the causes, prevention, and treatment of cancer and other diseases. Say, I'll tell you what are the other diseases we use, involving special expertise in the therapeutic applications of ionizing radiation. Ionizing radiation, I underline, because what we use in radiotherapy department is ionizing hazardous radiation. Like in a room I'm sitting, we have a lot of tube lights. These are non-ionizing radiation. Even from your mobile phones, it is non-ionizing radiation, which has to, even that we have a limitation, how much we have to use. But what we handle are ionizing radiations, which can destroy the DNA of the tumors. What is radiotherapy? It's clinical modality dealing with use of ionizing radiations in the treatment of patients with malignant neoplasias and occasionally benign diseases too. Yes, now when I decide a patient can be taken up for radiotherapy, that we call in, according to radiotherapy medical ethics, as justification of treatment. Now, according to our ethics, it is when you have a superior or even equal equally effective modality, then we have to opt for that whenever the situation warrants. Say, at least when you're planning to deliver radiotherapy, it has to either cure, or at least improve local control, or it has to ameliorate a specific symptom, like when we palliate pain, or it has to improve quality of life. At least one has to be achieved. In that situation, you are justified in delivering radiotherapy to that particular patient. What are the goals of radiotherapy now? Yes, we have patients of different stages who come and meet us. So when we see patients with early stage, then we say the patient can be cured of the disease. That means, what is the real meaning is like we are going to remove all the cancer cells from the body. That's what we aim. So that is called curative radiotherapy. And then if I say no, already the patient is presenting in stage 4, they have metastatic disease, and they have severe pain. Pain is one symptom. It is not the only symptom we palliate. The one of the symptom which we palliate is pain. So that we are going to target only the symptom relief in that situation. That is called palliative radiotherapy. Whichever type of radiotherapy, now we decide what is the volume of interest. That means the radiation has to be exposed to the target area. Appropriate volume has to be treated. We should not expose any of the normal tissue to unwarranted dose. So, what are the techniques available to achieve the same? Now, we have teletherapy, that means external beam radiotherapy. As I told you, it's like a CT or an X-ray machine in which X-ray comes from outside and the patient is exposed to that X-ray. That we call it as external beam radiotherapy, in which we have multiple techniques. Now, we evolved, so as I told you, how we evolved over centuries. Now, in techniques, we have evolved from conventional, and then we moved on to 3D conformal radiotherapy, and then intensity modulated radiotherapy came, and now we are in the era of stereotactic radiosurgery and radiotherapy. Now, what is this actually? Is it like it makes some sense and it's just types, or it's like Browns like LP or VH? No, it's not like that. It's like we have evolved in the sense can use any kind of technique for any kind of patient. Only thing, what is the main differences? The cure will be the same. Say if I tell you conventional is going to treat the patient in the same way, the tumor will respond the same way. Even if you're MRT, what you're going to choose, the tumor is going to respond the same way. Then what is the difference? When we do conventional radiotherapy, now if you see the picture here, now this is conventional radiotherapy, in which those days when we were students, we could deliver even for an irregularly shaped target. The exposed area will be a square or a rectangle. That means what? All the surrounding normal tissues which are very close to the tumor will be getting the same dose. From there, we moved on to conformal radiotherapy, in which we can at least shape the field in the shape of the tumor. At least we can produce irregular fields. But inside that irregular field, the dose received will be the same. We cannot modulate the dose in that situation. Now, how are you going to plan radiotherapy? So very important is, now the patient is going to get exposed. Machine is a moving machine. It can rotate 360 degrees. But at the same time, the tumor, if say, for example, we are going to treat the neck, then in that situation, the patient has to be immobilized first, because to repeat it, the radiotherapy is not one day program. It is continuous 30 days or 35 days. The patient has to be reproduced in the same manner, the same way which we do on day one. So in that situation, the precision and accuracy has to be maintained. For that, we try to immobilize the part which is exposed for radiation. Say this is the picture which I put for a head and neck patient who's planned. So this is how we immobilize. This is called a mold. And then this is like very much breathable. You can see many holes in that. And then it is very comfortable for the patient, because they have to just lie with the mold only for 3 or 4 minutes. That's the treatment time. So first step will be the position of the patient according to the site of tumor. And then we immobilize with the mold like this. And then we do a CT imaging in this position. And the CT images will come to my computer. And in that, we will be voluming. Say the team which is going to do the planning is medical physicist team. They are medical physics experts, but they are not doctors. So that means the anatomical information is given by the oncologist. So we, in slice by slice, we volume, say even if it is 300 slices, we have to volume the normal structures separately, and we have to volume the target. That means the tumor area. So that my physics team will know which is the area to be targeted with high dose and what are the structures to be spared. And then after the planning is verified by the oncologist and approved, the plan is sent to the machine, because it's all integrated system for us, computerized, and then it is executed. And day one, the plan is also verified by the oncologist and the physics team. So from conformal, then we evolved to IMRT. What is this IMRT? Intensity modulated radiotherapy. As I said, now you make irregular field. Even within this irregular field, you want to modulate the dose. Say if I'm going to treat a cervix patient, say we are going to, especially in a post-op endometrium or a post-op cervix, imagine we are going to treat only the microscopic disease, but there is only normal structure inside. Because the pelvic cavity is empty, we have more small bowels, large bowel, bladder, everything is normal structures. If we want to reduce or modulate the dose even within the field, it is possible with this new technology. That's the advantage. Now you can compare in this picture how nicely we can reduce the dose in this area, where it is like butterfly shaped. But if you see the first picture, we can do only this kind of square fields, which we call, even with the target volume given to the physics team, it's not possible with the normal 3D or the conventional protocols. And now see how nicely the small balls are spared in a case of pelvic planning. And this is a dose volume histogram in which we compare what is the normal structure dose and what is the target volume. And we have proper constraints for every structure. And it's important that we achieve the constraints. And then the other technique which is available in radiotherapy is brachytherapy. It is internal radiation, which is most of the time we use in a cancer cervix, especially after EBRT. And then it is like after we reduce the volume to the residual disease, we can give brachytherapy. And we do use brachytherapy for intraluminal situations like bronchus and esophageal lesions, and interstitial, say soft tissue sarcomas and breast, and superficial structures like mold, which can be used for skin cancers. Now, this is brachytherapy for a cancer cervix patient. Even here, we have evolved from a 2D technique to 3D. Now, 2D in the sense, those days we can image only with an X-ray. So, we have put the applicator in, and then we have taken an X-ray in AP and the lateral, and we calculate. Now, this is the bladder area, which is displayed by the Foley. And then this is the rectum, which we have identified with a lead wire. We have to make these structures radio opaque so that we identify on an X-ray. But now here we can calculate doses roughly only, because we know the lead wire is inside the rectum and the bulb is inside the bladder. And this is the area, because we have already inserted the tube inside the uterus. You know, this is the uterus and the cervical and the phonesis. So this is how we used to calculate, and this is fed into the computer and we generate the plan. This we call it as two-dimensional planning. Now imagine this is the new applicator we have upgraded even in our unit now, Sriyor. Now here we do a proper CT imaging. You know where is the tumor. You can volume the tumor. You know the rectum. You know the bladder very well, even whether you put a rectal tube or not. You can see, visualize, and you know what is the anterior wall receiving, and you are confident that how much dose you are receiving to the whole of the residual volume. Same thing here. This is a 2D X-ray planning for, you can see the typical rat tail appearance of a esophageal tumor. We did for symptom relief as a palliation, metastatic esophagus. So this is opened up very well. And this is a 2D planning, which we did many years before. But now the same thing, see, you can do it is in 3D. Like this is a CT image in which you know where is the tumor. You can be very confident. Say that image guidance always gives you the superior confidence. You know where you are putting the dose and where the dose is falling, and you can visualize it, understand it. This is again our old case of 2D planning for a thigh sarcoma, in which we did interstitial implants, and then we did a 2D planning. This is called interstitial implants, but not like those days. Those days they used to put radium needles itself inside the tumor. Now these are empty needles which we put it in the theater after the surgeon removes the sarcomatous tissue. In the post-op bed, we put the needles in the theater, shift to the brachytherapy suite, and then we have machines which has the source inside. Here it is iridium. Now the source is inside the machine, and nowadays it is computer controlled. We can stay outside in the console and we can operate from outside. The source goes inside each needle one by one, and then the post-op bed where we have to treat will get treated. So this is how we do nowadays. Yes. Now, what are the major modalities? Now we have to know why radiotherapy. Why at all we use this modality? Even we know this has a lot of. I mean, we do have problems with using this modality. Now, what are the major modalities for cancer treatment? We have only three major modalities. We have the surgery, time tested, and then radiotherapy. Almost it started as close as a surgical, though not so like Sushruta's age. But after that, maybe in 1.5 centuries before itself, it has started. Chemotherapy is, of course, a latest branch, which added lot of drugs to the treatment of cancer therapy. Now, how you decide when and how you are going to do which modality is the best at what? That depends on when the patient comes to the clinician. Say the stage of the disease. For early stage, we need only one modality. Say, for example, where I highlight only radiotherapy part, others I think surgeon will tell you. It's like for early stage disease. Say, for example, a patient comes to me with a very early stage glottic tumor. That's one place we still have radiotherapy as the single modality for cure. Why we use it? Because we still can do when we weigh. So why it is like, why we have moved on from surgery in laryngeal tumors to radiotherapy? Yes, we have to achieve cure. That is one thing. Second point, nowadays, what is the important point in ethics in oncology management is preservation of organ. If you are able to preserve the organ, then that modality gets a little upper hand. So here it is like you are able to cure, at the same time you preserve the larynx, and you also reserve surgery when there is a recurrence. So you have multiple reasons why we opt. So that is why we decide this is for this only we have the tumor board, and we decide which modality is superior and which is okay for that particular case. It is decided case by case. When we have moderately or locally advanced tumors, now definitely I told you how the disease keeps coming down with one modality. And when you have large amount of tumor cells in the body, then definitely you cannot handle with single modality. That time we add one more, or sometimes we add all three modalities according to the requirement of the patient. When it is metastatic disease, according to most of the cases will receive only chemo. Sometimes when we have pain, or when we have some, say for example, even in RCC, say kidney tumors, as a palliation we do surgery. So even surgery can be done in a palliative intent. That again, it is dependent on what tumor and what the patient needs. Yes, why radiotherapy? In general, when tumors grow in size, it cannot be controlled with single modality. That is the reason. And according to the site. Now, say for example, if our surgical team operates on a head and neck tumor, and the biopsy report is generated, and in that we look for high risk features. Now we say that the pathologist is highlighting some features which says yes, this tumor has higher chance of recurrence. Then those are the tumors which the surgeon will automatically refer for a localized radiotherapy planning, so that it is better that we can keep the patient, preventing the patient from recurrence. Same way how we combine. If it is a locally advanced tumor, then we have to combine chemotherapy and radiotherapy. So everything is dependent on the site and stage of the disease. Okay, when will we add radiotherapy? Now we can add radiotherapy either prior to the primary modality of treatment, that is called neoadjuvant, in which tumors like sarcomas, even now we do for oral cavity tumors, even breast, if they are not getting controlled only with the chemo as a pre-op. And then when we do concurrent, say for example, one and the other modality goes hand in hand. We start radiotherapy and chemotherapy on day one for a locally advanced head and neck cancer, similarly a locally advanced cervical cancers. What is adjuvant? That means it is after primary modality, like breast, head and neck. After surgery, according to the biopsy, they send. In lymphoma, post chemotherapy, the lesion which was really large, especially mediastem, the site which is we call it as high risk sites, those sites they refer for involved field radiotherapy as an adjuvant. Okay, now what is the role? Is there a role, first of all, of radiotherapy for benign diseases? Yes, we do have, but why do we give? Is it really necessary to irradiate a benign tumor? Sometimes it is required because you are preventing the recurrence of a benign tumor. Here, the aim of the radiation oncologist is not to make the tumor disappear. Kindly understand, benign tumors will not disappear for the dose which we are giving. The dose we are giving is helping further regrowth of the residual disease. So it causes growth arrest in case of benign tumors. The most common tumors we are irradiating are pituitary adenomas, craniopharyngiomas, acoustic schwannomas, other rare tumors which we see, or it's not tumor actually, the conditions are myositis ossificans, otherwise called heterotrophic ossification. Commonly, we get cases from Ganga Hospital. It's a very planned operations. Like they send the patient first day for planning, next day for execution, and third day they operate. So it's a planned program. And then we have keloids, which is not amenable to other treatments. And of course, some cases of villonodular synovitis. Yes, this is the case of heterotypic ossification. Like very classically, you can see how the deposition after road traffic accidents, and the patient is immobilized for a long time. They get large overgrowth of the osteoblast like this. So it is like it immobilized. The patient can't move. The patient has severe pain. This has to be excised. The problem is once they excise, if it is left again there is a possibility of recurrence of the same condition. So what we do, we give a single 8 gray, which can be delivered, with a single 8 gray. You can give just 8 gray single, but it has to be done 24 hours before surgery, or it has to be given 72 hours post surgery. The timing is so important, especially in conditions like this. This is a earlobe keloid, and then the keloids, again, the patients who are not they are not responding to any other treatment like intralesional steroids. We have had plastic surgeons calling, and we have seen patients in which almost the earlobe is lost. So this radiotherapy is taken as a last step in which they prevent recurrence. But again, it's so important they excise even marginally, but they send the patient within 48 hours of surgery. In that situation, we can take the patient and we deliver 20 gray in 5 days, so that the response is good till now. So this is a plan in which you can see a pituitary. This is a macroadenoma. It's a large disease. Again, the size matters definitely for deciding what kind of technique. It's like the size is more, then there is no point giving the highest, say, stereotactic radiotherapy, because again, the chiasma dose will be so high. So we cannot deliver doses like that. It is only a normal 3D plan. This is the larger macroadenoma. But here, if you see, this is our case with a very small pituitadenoma in which we did a VMAT. And this is a proper stereotactic planning in which we can even protect a very minimum dose. Chiasma has to be at least 6 mm away from the target volume. These are other benign conditions like CP angle schwannomas. This is a carotid body tumor, which is generally referred from our surgeons. If it is not encircling if they feel surgery is a little tough in that site, or even as a post-op, we have treated tumors. And then this is a craniopharyngioma. Yes, what are the radiotherapy myths, which is very commonly the public has, and as the referring physicians, what you have to tell to these patients? Radiotherapy is painful. This is what they think, but it is not so. Actually, say, for example, once the patients start responding to treatment, especially say oral cavity tumors, because the tumor is regressing and the patient is developing mucositis, that only causes pain. It's not the therapy as such, it is not painful. Will it cause will it make the patient radioactive? Please don't get confused here. It is not it is not making the patient radioactive. Just imagine, it is just like doing a CT scan. How the patient walks into the radiology department, gets a scan done, and goes home and be normal. Same way, the patient can undergo radiotherapy, go home, and can be very much normal with other people, because this is the common question which my patients and their attenders used to ask. It's like whether I can carry the child, whether I can be with my pregnant daughter. Everything is possible because the radiation is over here itself in the room. Radiotherapy will cause me to lose my hair? No, unless if I treat the scalp portion. Say if we treat a scalp squamous cell carcinoma of the scalp, or we are going to treat a brain tumor, which is very close to the skull bone, where I have to deliver a little more dose to the scalp. Otherwise, generally, it is not hair loss is not a side effect of radiotherapy delivering at some other site. Radiotherapy will cause nausea, vomiting. Again, it is not a direct effect. If we treat any portion of the gastrointestinal tract, then it is possible. Okay, people think that we are going to implant wires, and they have weird ideas about radiotherapy. No, it is not like that, just like doing a CT scan. And whether it will mutate genes and getting passed on to next generation? No, not at all. It's like what we are worried is the low dose exposures, which is usually happening for the attenders and all that. This is what we scare in the older generation. Like say I'm telling over one century, or I mean half a century before, because radiation was not controlled well. But now it is not like that. You can even sit and eat in our console. It is so safe. Radiotherapy is like electric shock or burn injury? No, definitely not. And is there any advantage of giving radiotherapy after complete removal of tumor? Common question, especially if my surgeon refers a patient after complete removal of disease. They say margins are negative. The first question they will ask, Ada ella edutitaangala yen radiation kora sollirukanga. This is how they ask me. Yes, it is necessary. That is why the surgeon knows definitely better than the people. You can Google, you can study, but understand nobody becomes a doctor after Googling in one day. So it is out of experience, and we know we have a guidelines, and we tell according to the guidelines. Yes, you have a chance of recurrence. Your biopsy report shows some high risk features. Then it is definitely needed. Then you have to undergo radiotherapy. And radiation, the word itself is just scary. This is what people keep telling. Yes, even people call me current doctor, and still it is called current treatment. But maybe another a few more years, everything will change for good. And this is the team. We work all together. I'm sorry, it's an old picture, so I think Dr. Mohan is not there. It's a team which works 24/7 in our Srior. And thank you for the patient listening. Thank you so much.
Thank you, Dr. Karthika, for your excellent talk. Actually, you are known for your clarity and the depth of knowledge in your subject, and even a lay person can understand your talk.
Thank you, sir.
A nice talk, and actually, I used to quote both yourself and Dr. Krishna Priya for examples. I mean, people are choosing radiotherapy as a study. They'll be worried about radiation, so I used to quote both of you and go and see those doctors and come. So you're really, both of you are motivating to others, and thank you so much for your talk.
Thank you,
And
sir.
now I would call upon Dr.N. MohanaRaj, surgical oncologist, for his lecture.
Thank you, sir. Thank you for the kind words. Good evening to one and all. The topic that I'm going to discuss today is regarding the role of family physicians or general practitioners in oncology. What is the role of family physicians in our healthcare system? Family physicians are like a boon to our healthcare system, without whom our healthcare system will get paralyzed. They are the first contact point with whom most patients consult. Most of the time, they are the one who have won the trust of the patient, with whom most patients shares not only their health issues but also his family matters. Often, they are considered as a part of their family. Patient, and at the end of the day, patient will eventually consult or go to the doctor or super specialist whom they refer to. So most of the time, it is the trust the family physicians, the patients has on the family physicians. So and that is where they go to the referral doctors also. Especially in a country like India with a huge population, family physician, where even in peripheries and even in small villages, family physicians play a vital role in optimizing cancer management, and they form a strong basement in cancer management pyramid. Because cancer is one disease where the accurate diagnosis, optimal evaluation, and timely initiation of treatment will make a vast difference in the survival rates of patients. Especially so, the role of family physician in in optimally diagnosing and managing the patients in oncology is very, very important, and it's unremarkable. Because cancer is not like other disease. It is one disease which will not wait for any reason, and it will eventually progress over a period of time. So even any delay in diagnosing the cancer and treatment initiation will lead to the stage progression. So, and that will in turn affect the survival of the patients, and the more the treatment the patient has to receive, which in turn will increase the morbidity to the patients. So, in this presentation, I would like to present with few oncological clinical scenarios which are commonly encountered by the family physicians, and I would just like to give some basic guidance for the management of the same. So, beginning with the most common clinical scenario that is being encountered by a family physician is women presenting with a breast lump, whether it is a benign lump or it is a malignant lump, or how to rule out malignancy. There are a lot of confusions among the family physicians regarding the same. So, I'd like to throw some light on this topic. The first point that I would like to suggest is breast cancers are now increasingly becoming more common in younger generation. Previous and even data suggests that Indian women are affected by cancer breast a decade earlier than Western population. The most of the time we think that cancers are disease of elderly. No, it is not that way. Uh, of late, recently, women of younger age group are being increasingly affected by breast cancers. In our institute, we have seen women with as young as even 20 years, 24 years are being affected by breast cancer. So the myth that breast cancer can occur only in elderly people and it does not occur in younger generation is does not hold true anymore. And so, what are the lumps that needs to be given importance? Not any painless lump of recent onset and that is progressively increasing in size needs to be addressed. And as thought, malignancy need not be always hard and fixed to the underlying structure like chest wall, muscle, and with overlying skin involvement. Even malignant tumors in early stages can be mobile, firm, and can mimic a fibroadenoma. So, what needs to be done? It's always better to get when you have a patient with a breast lump presenting to your clinic, it's always better to have a baseline imaging done. So, for women less than 30 years, 35 years of age, it's better to get an ultrasound of both breasts. And for women more than 35 years of age, better to get a sonomammogram of both breasts because in younger women, the breast glandular tissue will be more, and that the ultrasound of both breasts will be more useful than the mammogram. This is the breast imaging reporting and data system scoring, which all the radiologists would give after imaging of the breast. This BIRAT scoring is very, very important because it helps us to guide the further management of the patient with a breast lump. Here, BIRAT scoring of 0 is incomplete because that will need an additional imaging, whereas a score of 1 suggests a negative report, negative find for malignancy. Whereas a score of 2 is a benign tumor, whereas a score of 3 is probably benign. In a score of 3, there is only a less than 2% probability of malignancy. Whereas for a score of 4, there is a highly suspicious of malignancy. There, the risk of malignancy is between 2 to 94%. BIRAT score 4 is further divided into 4A, 4B, and 4C. BIRAT score 5 is highly suggestive of malignancy, which carries a more than 95% probability of malignancy. BIRAT score 6 indicates a biopsy proven malignant breast lump. So, what is to be done after imaging? Always it's better to establish a tissue diagnosis. Any lesion which is BIRAT 4 and above will definitely warrant a further evaluation by tissue diagnosis. Now coming to the next thing, what tissue diagnosis? What is the tissue diagnosis that needs to be established? Most of the time, we tend to do an FNAC because it is easier and cheaper. But an FNAC can neither rule out and nor confirm malignancy because in our institute we have numerous cases where the FNAC has been reported as benign and the final report on excision biopsy has turned out to be malignancy. So an FNAC is a very, very, very small investigation to confirm or rule out malignancy. The minimal recommended biopsy by international standards for any breast lump to establish a tissue diagnosis is a core needle biopsy, commonly called a true cut biopsy. So when most of the time, what is when do we need to do an incision biopsy? Incision biopsy is done only if repeated at least twice core needle biopsy is negative because incision biopsy may lead to tumor spillage and tumor contamination of the field. Especially if the patient is a candidate for breast conservation, it might hamper the it may prevent the patient from getting the same therapy done. And most of the time, the true cut biopsy or corneal biopsy is not done at peripheries because of the fear of post biopsy bleeding from the tumor. The thing that I want to stress here is all the post biopsy bleeding will eventually stop with pressure dressing. So no need to panic about the post biopsy bleeding. So, and most of the time, we have encountered so many patients where a breast lump has been excised without a proper pre-op tissue diagnosis, and they have been referred to us. In that scenario, the problem with doing an excision biopsy without proper pre-op imaging or a proper tissue diagnosis is that the patient is denied the chances of breast conservation if for deserving patients. And also, an excision biopsy may lead to tumor spillage if the excision biopsy done is margin positive. Or there are few scenarios where the patient would have a breast lump and a huge node in the axilla who are candidates for upfront neoadjuvant chemotherapy. If the excision biopsy is done, that might cause a delay in the initiation of treatment because the time will take for the excision biopsy wound to heal. Then only we can start the neoadjuvant chemotherapy. This will further cause a delay in treatment initiation of treatment. The point that I would like to stress in a patient presenting with breast lump is the patient presenting with breast lump often during pregnancy and lactation. Inflammatory breast carcinoma is one entity which commonly occurs in young women, especially during pregnancy and lactation. The most problem with this, the important problem with this is that it often mimics a lactation abscess or a lactation mastitis. So, any mastitis that is not settling with adequate antibiotics have a suspicion on inflammatory breast carcinoma. When in doubt, it's always better to get an imaging done. So next clinical scenario I would like to do is discuss this. The patient, women presenting with an abnormal uterine bleeding or white discharge PV, carcinoma endometrium, most commonly presents the most common clinical presentation is with a postmenopausal bleeding PV, whereas CA cervix often presents with a abnormal white discharge PV. The point that again I would like to stress here is that carcinoma cervix, carcinoma endometrium can occur even in young and middle-aged women. Ages have gone where cancer has been thought only as a disease of elderly. We have seen it at our institute the women with carcinoma endometrium as young as even 18 years of old of age, and of late we are seeing women premenopausal women being increasingly affected by carcinoma cervix and carcinoma endometrium. So what needs to be done? It's always better to get an imaging done before surgery and before planning the patient for any surgery. It's better to get a proper tissue diagnosis. For a carcinoma endometrium, we can go ahead with a Pippel's curettage or a dilatation and curettage. Whereas if a patient is suspected to have carcinoma cervix, then punch biopsy of suspicious area in the ectocervix will be helpful. uh, the few people might think any of for carcinoma of endometrium or a carcinoma of cervix, any of the uterus needs to be removed, and they don't, at the end of the day, only hysterectomy is the treatment of choice. So why not we go ahead directly with the hysterectomy instead of establishing a pre-op diagnosis and wasting time and money? No, that is not the scenario, because the type of hysterectomy that is being done for a carcinoma of cervix or a carcinoma endometrium varies totally than we do it for a benign condition, because the radical hysterectomy done for malignancy involves removal of parametrium and a vaginal cuff along with the routine hysterectomy specimen. Also, if it is a biopsy proven malignancy, we have to address the nodal dissection. Both pelvic and para-aortic nodes needs to be addressed based on the nodal condition of the patient. There may be few patients who are not at all a candidates for surgery and who can be totally cured by definitive chemoradiation alone. In those patients, the surgery can be totally avoided. So it is very important for these patients to establish a proper pre-op diagnosis before starting any treatment or proceeding with hysterectomy. The next common clinical scenario encountered by family physicians are a patients presenting with a ovarian mass or adnexal mass. The ovarian mass, the problem with ovarian mass is unlike CA cervix or CA endometrium, most of the time it presents with vague symptoms like abdominal discomfort, abdominal distension, or a dyspepsia, or loss of weight and loss of appetite. That is the reason why most of the ovarian malignancies in India are diagnosed in advanced stage, especially in stage 3. That is the most common stage of presentation of ovarian cancer in Indian scenarios. Malignant ovarian tumor can closely mimic or it can even present as torsion ovary. Again, the point that I would like to stress is there are increasing number of ovarian cancers being encountered in young and middle-aged women. Germ cell tumors are commonly encountered in the second and third decade of life for in second and third decade of life in any woman. But what is the imaging to be obtained? Both CT and MRI are equally effective for evaluating an ovarian malignancy. CA-125 and CEA to be done if suspicion of malignancy is high. Again, the point to be stressed here is CA-125 can be normal even in poorly differentiated malignancies or even in mucinous neoplasms or borderline neoplasms. CA-125 can be normal. And in young women for whom suspicion of germ cell tumors is there, it is better to get a LDH, AFP, and beta HCG. And while planning treatment for a patient with ovarian mass who has a suspicion of malignancy, it's better to get it done in a center where frozen section is available, because intra frozen section will help us either to confirm or rule out malignancy. Why this is important? Because if the malignancy is identified intraoperatively, then we may avoid the second laparotomy that is needed to do a complete omentectomy, nodal dissection, both pelvic and parantic, and peritonectomies. All so the patient may be avoided a second laparotomy, and both the treatment can be completed in one sitting itself. And again, laparoscopy can be done for ovarian tumor management. But the point to be noted is tumor spillage or cyst rupture to be avoided, because a patient who has an ovarian mass confined to ovaries will not, and if it is a low grade tumor, they will not warrant adjuvant chemotherapy. But if we rupture the tumor intraoperatively while delivering it through laparoscopy, then we might need to give them the adjuvant chemotherapy. So, by avoiding tumor spillage and cyst rupture, we can avoid the chemotherapy and side effects of chemotherapy to a patient who doesn't need it actually. That is why the point that I would like to stress is if you want to do a laparoscopy for ovarian tumor, it's if the tumor can be removed without spillage or rupture, we can proceed with laparoscopy. But if the fear of tumor spillage or cyst rupture is there, it is better to avoid a laparoscopy and proceed with open surgery. The next clinical scenario that commonly encountered is the patients presenting with epigastric discomfort, persistent dyspepsia. So, any patient who has a persistent dyspepsia not relieved by proton pump inhibitors, especially of elderly age group, will warrant an upper GI endoscopy or OGD scopy, and all suspicious areas needs to be biopsied. Early gastric tumors may not be picked up by the ultrasound. All patients who are suspected to have an abdominal malignancy will need a minimum of CT abdomen pelvis with oral and IV contrast as an investigation of choice. OGD scopy is always superior to ultrasound for detection of early stomach cancers. While coming to the treatment of carcinoma of stomach, all tumors more than T2 stage and all node positive tumors will need neoadjuvant chemotherapy before proceeding with surgery. So also, even if because the patients with any higher stage tumors, if upfront surgery is done, the studies have proven that the chances of both local and distal recurrence is high, and this in turn will affect the survival of the patients. Also, the type of surgery done for all gastric tumors is a D2 gastrectomy with nodal dissection along the major vessels of the abdomen. That is the treatment of choice and surgery of choice done for patients suspected with CA stomach. The next most common present clinical scenario encountered is patient presenting with a difficulty in swallowing. Any dysphagia that is persisting for more than 3 weeks and that is progressing from solids to liquids, especially a painless dysphagia, is more alarming, and we need to scopy the patient with the persistent dysphagia. OGD scopy is needed to rule out any carcinoma esophagus, post-cricoid region, and piriform fossa. Again, a CT imaging of upper abdomen and a thorax will be needed with contrast for the investigation of choice. Most patients with carcinoma esophagus are managed with definitive chemoradiation without a need for surgery. Patients with colorectal cancer commonly present with bleeding per rectum, altered bowel habits, and passing stools. All patients who have an abdominal symptoms, it's better to do a rectal examination or a digital rectal examination. Patient will further need colonoscopy and a CT scanning with a serum CEA to be done. The all colonic tumors are commonly treated by surgery, but that is not the scenario with the rectal tumors. Rectal tumors, most of the time, especially in Indian scenario, patients present with a stage 2 or stage 3 disease. All patients with rectal tumors, except stage 1, will need a neoadjuvant chemoradiation, because most most of us will think that any patient will need chemoradiation. We can give the same after surgery. That is not the scenario. Oncology, we have three treatment modalities: surgery, chemotherapy, radiation. It is a sequencing of treatment that plays a major role in deciding the cure rate of the patient, especially whether they are local recurrence free or distant recurrence free, and increasing the survival rate of the patient. So, the any patient with rectal tumors, they are most of the time candidates for a neoadjuvant chemoradiation, and that has to be considered. Also, the by giving neoadjuvant chemoradiation, we can avoid permanent fecal stoma, and that will benefit the patient from further unnecessary permanent fecal stoma. And patients with renal tumors or bladder tumors commonly present with an unexplained or persistent hematuria. Ultrasound is good enough for a renal tumor, but it can miss early bladder tumors. Again, CT abdomen pelvis with IV contrast is the investigation of choice for genitourinary tumors. Renal tumors are most often managed by surgery. Bladder tumors, if detected early, we can avoid radical cystectomy and permanent urinary stoma. The most commonly encountered clinical scenario by most of the family physicians in their setup is patient presenting with oral ulcers, whether they are benign, whether they are malignant. We have a lot of doubt in it, especially in country like India, which is a home for oral cancers, because of the increasing substance abuse like tobacco, alcohol, and among our population. And of late, we are seeing a lot of youngsters and middle-aged population being increasingly affected by oral malignancies. When to evaluate an oral cancer? Not that all patients who present with oral ulcer will need further evaluation. Any ulcer persisting for more than 3 weeks of duration despite treatment, and especially with patients with elderly people with unexplained loosening of tooth, with difficulty in mouth opening, that and with the presenting with an ulcer that might bleed on touch with averted edges, and which is non-tender firm neck nodes, are highly suspicious of malignancy. When these clinical scenarios are encountered, it is better to evaluate the oral ulcer further. All suspicious ulcers needs to be biopsied. Why earlier detection is important in oral cancer? Because if they are detected earlier, the amount of treatment they receive will be less, and this in turn will cause them less morbidity. And most of the time in Indian scenario, oral cancers are referred only at an advanced stage, which will make the patient need an extensive surgeries like commando operation, and they will eventually have to undergo radiation chemotherapy, which along with the side effects of both all forms of treatment, which in turn will affect the quality of life of the patients too. Uh, And another common scenario encountered by family physicians are patient presenting with the enlarged lymph node. Any painless, firm or hard lymphadenopathy without underlying etiology needs further evaluation. The next point that I would like to stress is FNAC again cannot differentiate a patient with from tuberculosis from lymphoma, because there are n number of cases where the patient has been started on ATT based on an FNAC report, and they will not respond to the ATT treatment, and when a tissue diagnosed by a excision biopsy is done and it has turned out to be a lymphoma, this will cause delay, not only delay in treatment of the patient, but also it will cause to the stage progression. Currently, there is no role for starting empirical ATT or steroids. All patients presenting with lymph nodes without an underlying etiology like infection or inflammation or a persistent lymphadenopathy will definitely warrant a further evaluation, either by a core needle biopsy or an excision biopsy. Next common Patients with carcinoma lung often present with persistent cough and hemoptysis, and early lesions may not be picked up by chest X-ray always. A CT chest needs to be done if symptoms persist. So, the commonly encountered scenario, that is patient presenting with lump at any sites. The point that I'd like to tell is any lump at any site, it's always better to evaluate before planning for action or any form of treatment, especially a lump that is of short duration, recent increase in size, that is painless with along with presenting with bleeding or ulceration, and the hard fixed lump with overlying skin environment. All these are features which will help, which are point towards the malignancy, and they will definitely warrant further evaluation. When in doubt, always ask for a local part imaging and corneal biopsy to rule out malignancy. Any patient with chronic ulcer, it has a possibility of being a marginal ulcer, so it's better to do a biopsy from the ulcer and then proceed with treatment. The last topic that I would like to discuss is regarding the pediatric tumors. Even malignancy is even commonly encountered in children. Any child presenting with a swelling or a lump in the bone or along with a night pain, always ask for an X-ray of local part to rule out osteosarcoma and Ewing sarcoma, because osteosarcoma and Ewing sarcoma are commonly encountered during the first and second decade of life, and most of the time these family physicians are misled by the history of trauma that the patient gives. The trauma might have made the patient to notice that swelling. It might be most of the time it's an incidental finding. So in uh, kids presenting with an unexplained swelling in bone needs further evaluation by further imaging. Also, most of the improper biopsy, if it is done, it may lead to tumor spillage and avoid the chances of limb salvage. This in turn will lead to the amputation of the limb, because the biopsy is not planned along the surgical site, or if an incision or an open biopsy is done, that might lead to tumor spillage and will avoid the chances of limb salvage and leading to amputation of the limb. Also, patients with unexplained weight loss with increased blood count suspect leukemia or lymphoma. Pediatric patients, brain tumors are the most common pediatric tumors. Any kid with persistent headache, unexplained seizure episodes, and cranial nerve palsy suspect brain tumors. So, the take home message is any patient who are presenting with a symptom that is persisting, that is for more than 3 weeks duration, better to evaluate further. Always evaluate before starting any form of treatment, because it's always better to have a correct diagnosis before starting treatment. The point that I would like to again and again stress is cancer is no more a disease of elderly population. Youngsters and middle-aged people are being increasingly affected by cancer, especially in countries like India. But the reason we are not able to identify it could be because of the changing lifestyles, increasing usage of gadgets like mobile phones, tablets, iPhones, or laptops. But the exact etiology of the shift in trend of affecting cancer towards younger people, we are not aware. But even in youngsters or middle-aged people, always have a suspicion of cancer at the back of your mind. The Also, in disease like cancer, early diagnosis is a key to management of cancer. So the earlier the patient diagnosed, the lesser the treatment needed, lesser the morbidity the patient suffers from, longer the survival of the patient, and better the quality of life. So early diagnosis, optimal evaluation management is utmost important in cancer care. Thank you.
Thank you, Dr. MohanaRaj.
Thank you, sir.
Your talk also is very simple and easily understandable to all the family physicians and general practitioners. And I also learned a few points. Thank you so much for your interesting talk.
Thank you, sir.
Any questions from the audience, from the participants? Any questions from the audience to both the speakers?
small point to add. What you said is perfect and true. That index of suspicion is one thing what we have to have in mind. We always have the physician should not have the mind towards thinking that patient will always have good disease. The disease will still be good, but they should have the high index of suspicion and took steps for early diagnosis. That should be the carry-home message. That we should have very high index of suspicion whenever we see a lesion in any patient.
Bhargavi, you're not audible.
Sir, I just said that we should have a very high index of suspicion. Can you hear me now? Can you hear me now? Our index of suspicion should be really high. Whenever we see a lump or any lesion in any patient, we should hope for the best but be prepared for the worst. So we should always think that it might be disease and investigate towards diagnosis. That's what I was wanting to say.
Okay.
Thank you, sir.
If there are no other questions from the participants, I'd like to thank Dr. Karthika, radiation oncologist, and Dr.N. MohanaRaj, surgical oncologist,
Thank you, sir.
for their participation today and sparing their valuable time here. And I also, on behalf of the management, thank all the participants who have logged into this seminar today. And we'll meet next month for similar interesting topics in the third week of March. Thank you, one and all.
Thank you, sir.
Murali,
Sir, thank you, sir.
we can log out.
Yes, sir. Thank you, sir.